Hello, everyone. Good evening. My name is Hassan Maghaireh, and I'm very glad to meet you all today as part of botiss Academy webinars. I send you all my regards wherever you are, all around the globe, from Leeds in the United Kingdom. Today, I've been asked to talk about bone block grafting, but with a special twist. We're going to talk about allograft bone blocks, the why and how of effective block grafting in implant dentistry. So I am a clinical teaching fellow at the University of Manchester, and I'm also proud to be the head of the scientific committee of the British Academy of Implant and Restorative Dentistry, BAIRD, where we run short and long-term courses in the United Kingdom, in Europe, and in Dubai and all around the world. I'm also involved with research, and I teach in different international events. I'm a private implant dentist after all, and today I will try to share with you my clinical experience in my private practice. I'm sure whether you're in Leeds, you're in Morocco, you're in South Africa, or Macedonia, anywhere, it's the same issue. You're going to have a patient coming to you with a broken tooth or tooth needed extraction, and they want to have an implant. But actually the challenge in 2019, our 18 and 19, our patients are well educated and they would like to have something which looks as natural as possible. So having an implant itself is not enough by itself. People would like to have something which looks natural. And when we talk about natural appearance, we're talking about bone. So obviously you have to build a bone in a predictable, a reliable way, so we can have good soft tissue, especially in the transitional zone, after which you can easily achieve white aesthetics. But for all this to be stable, we know from Spray et al. And his research that we need a minimum of 1.8 millimeter to have long-term stability. As studies showed, whenever we have a facial bone around the dental implant, less than 1.8 millimeter, there will be high risk of vertical bone recession. So the challenge is trying to put the implant in the correct position, obviously, because it's all about putting the implant in the correct position, building healthy bone around that implant to give us long-term stability. And as I keep telling my colleagues and my juniors, this is a system being described a long time ago. This is one of the best articles in aesthetic implant dentistry by Danny Boozer and Ers Bilzer and their group, where they gave us the roadmap to optimal aesthetic implant restorations. And it starts by correct implant positioning. Obviously, you need to have good bone quality and quantity, sufficient healthy soft tissue, and correct prosthetic design. And yes, today we're going to mainly talk about good bone quality and quantity. We're going to talk about bone block grafting, but I think no implant lecture should start without focusing on the main issue, which is correct implant positioning. In a very recent review, they showed cases where the PINK failed and the aesthetic implant dentistry failed to be achieved was mainly due to failure in implant positioning. It's so easy for the implant to be placed to buckle. And that's why, yes, we know the three-dimensional implant rules, but I think it's to do with the fourth rule, where you need to place the implant within the prosthetic envelope, respecting the bony envelope. We know the cortical bone needs to be thick around our dental implant. If we put pressure on this cortical bone and it's thin, it's going to crack, initiate micro cracks, and within the first 6 months, you're going to have resorption. So all what you need to do is to place your dental implant a bit too labial in the wrong position for you to start to have bone changes, followed by soft tissue changes, and eventually something embarrassing. While in return, focus on your implant placement. Correct positioning will help you to create good bony envelope, good soft tissue support. But the challenge is, how do we provide that space? Because we know it is not always the case that we have sufficient amount of bone to help us to place implants in the correct position. That's why we're going to focus on how to provide that sufficient healthy bone to allow you to place the implant in the correct position, to allow your soft tissue to look natural, so then you can have healthy, nice looking crown. So the question is, when can we do guided bone regeneration around our dental implants? We all know from our biology studies that GBR will be very reliable and predictable whenever we have three-wall defect, basically placing an implant into a socket with an intact labial wall, or placing an implant with an intact mesial and distal bony peaks, even if we don't have labial plate. If we have these conditions, this is what we call favorable morphology, and therefore GBR will be reliable and predictable, and we can go for implant placement and simultaneous guided bone regeneration. However, if we don't have this three-wall defect or favorable two-wall defect, the only option we have to be able to place the implant in the perfect position and then therefore achieving reliable results is to go for a staged approach. And this is what I'm going to be discussing with you over the next hour or so. So if we have unfavorable defect, such as one wall defect, you've got one mesial wall, for example, but no distal bony peak, or you have a knife edge ridge, therefore no mesial or distal bone support, the implant will not give you good results even with extensive GBR. And the only way forward is to try to go for staged approach, where you do bone block grafting, you allow it to heal and integrate, after which you come back and place your dental implant within the correct position. This is what we call stage approach. And yes, you can go for autogenous bone, and we all know, and I'll show you later on, autogenous bone is considered the gold standard from a biological point of view, but I would like to argue that from a practical point of view, our patient's going to go through a lot of misery, a lot of trouble to get such results. While with these allograft blocks, we have data showing that we can achieve the same success rate at a fraction of trauma, morbidity, and mortality. And these blocks can be ready-made blocks, like what you can get from botiss maxgraft blocks, or you can go for the CAD CAM blocks, the bone builders. You could design the case based on your cone beam CT scan. You send it to botiss, you send the scan to botiss, they send you the suggested design, you check it, approve it or disapprove it, you do the amendments you would like to have, and before committing towards having the block, you could ask them to send you the dummy, which I found very useful in communicating with my patients and explaining to them why they need such bone grafting. Now, the dummy not only going to be a good communication tool, but also can help you in planning your surgery in advance. So this long operation can be shortened to literally half an hour or 40 minutes, not longer. So you're becoming more conservative, you're becoming more accurate, and you give your patient high-tech operation, achieving the same reliable and predictable results. And this is something I will be touching on and explaining towards the end of my presentation. So what I'm trying to show you that in 2018, we have reliable products which can give us good bone volume at a fraction of trauma, cost, and time to our patients. And the beauty of these CAD CAM blocks, they're pure cancellous, come from live donors, so they're very easy to market, very easy to tell your patients about, and then they fit accurately in most of the cases. But let's go one step back and let's go through one of the cases I've treated here in Leeds, and I show you a staged bone grafting workflow. This is my patient Star. She's a young lady, 28 years old. She lost her front tooth when she was around 17, and for the last 11 years, she had an adhesive bridge. Obviously, kept debonding, gave her a lot of reduce her self-confidence. So she decided she wants to go ahead with dental implant. And Star, trust me, she had really high expectations. So we did the planning, and as part of the planning, we did a CBCT showing that we have 2.5 millimeter crest. We have a huge and considerable amount of bone loss. However, we've got loads of palatal bone. Now, if we ignored the importance of correct 4D implant placement, you would easily look at this case and say, wow, I can angle my implant into the palatal bone. It can be quicker, easier. However, trust me, you do that, you're going to lose bone, you're going to have a crown which looks so embarrassing and very hard to correct. So we communicated with Star, and Star was clear from the beginning. She wanted something which looks natural. She wanted something which gives her confidence. She wanted something which she knows is going to be reliable and predictable, not today, not tomorrow, 5, 10 years down the line. So this is an occlusal shot to show you how much bone loss we have, and you could appreciate the fact that while we have some mesial wall, we didn't have distal bony peak. Therefore, I would call this a one-wall defect. So it was clear from the beginning, this is a case where bone block grafting will be needed. As part of the consent procedure, we went through the alternative options, and we said, Star, you could have your bone block from your chin, from your ascending ramus, or from the hip. We don't do this anymore, not in the dental practice. However, we could offer you something like simple, conservative, but still providing reliable results. Allograft blocks. Star decided to keep it easy. She decided to go ahead with the allograft block to be able to reconstruct the ridge so we can place a dental implant within the correct position. We went for a maxgraft bone block, and from there we put a membrane. We sutured everything nicely together, and we put her Maryland back. Definitely, whenever we want to do bone block grafting, the temporization has to be a fixed temporary. Because if you have a denture on the top of bone block, basically it's going to be your recipe for disaster, and that block will not integrate. As it's a unicortical cancellous block, we like to leave it about 5 to 6 months good healing. And this is something I will be talking to you about in detail towards the second part of this webinar. So 20 weeks down the line, we took another CBCT showing that we managed to go from 2.5 to 7.3 millimeter, which is good bone augmentation. I'm checking my soft tissue. I'm doing my bone sounding to be able to provide the best flap design. And from there, we went and raised the flap. And obviously, the moment you check that the block has integrated or not, you remove the screw, the fixation screw, and you see blood on that fixation screw, which tells you that this block has well integrated. It's becoming vital, and the whole remodeling process took place, and most of the block now is replaced but with natural bone. We place a dental implant within the prosthetic envelope in the perfect and ideal 3D and 4D dimension position in the anterior region, in the cingulum region, the shoulder of the implant, a minimum of 2 millimeters away from the future labial profile. From there, we achieved good torque, 25 Newton centimeter. I put some Cerebone xenograft just to give me the contour I like, and then we put a Jason membrane on the top, stabilized with some little tacks to give us stability, because we know to be able to achieve good GBR, it's all about providing stability for the bone underneath. We decided to go for soft tissue grafting. But again, we kept it minimum. We kept it easy for our patient. So we use mucoderm from botiss. And basically, it's a porcine soft tissue graft, and stabilize it using stabilization sutures, which will bulk the soft tissue and give us the thickness we want to be able to mimic the adjacent natural tooth. And we left it 12 weeks. The healing abutment started to partly expose itself. And as you could see here, we've got nice contour, nice amount of keratinized mucosa around our dental implant. Obviously, to do it properly, we need now to focus on the prosthetic soft tissue management, prosthetic soft tissue sculpture, and you do that using your temporary restoration. So we've got a temporary implant crown, starting with a round cross section. But every 2 weeks, you bring the patient back, add some flowable composite, and gradually start to contour your soft tissue until you reach a point where the zenith is matching the adjacent tooth, the gingival contour is matching the adjacent tooth, and you're happy with the contact points. You do that, and then only then you can be ready to do the final restoration impression. So we customize our impression pickup to show the lab the gingival contour and the subgingival profile, so you can build something acceptable. We did a CAD CAM abutment with a screw retained crown. I asked my lab technician to make everything subgingival, either concave or flat, because if we make it convex, it will put pressure on the gum and give us recession. And then we have a nice final restoration, screw retained, achieving the aesthetics our patient expect. But obviously, it's all about the pink. If the pink wasn't good, we wouldn't be able to achieve the white. But if the bone wasn't good, we wouldn't be able to achieve the pink. So it's like a puzzle all connected together. As you appreciate, we managed to build that nice convexity, and that's our screw retained restoration. And you could see here how the convexity, the alveolar contour around the dental implant is very similar to the alveolar contour around the adjacent natural tooth. And that's a lateral profile photo. It can help you to assess the convexity, the gingival zenith, the gingival contour. And here we go. At the time of the fitting, we've got a happy smiling patient. Imagine if the bone wasn't right and we placed an implant in wrong dimension, how much recession we would have. And then, it will be so embarrassing. So this is a lady who's got high smile line. We managed to give her dental implants, delayed dental implants. 10 years after losing her natural tooth, we managed to recreate everything she lost. And it started by proper planning. She had one wall defect, so definitely she needed bone block. But she wasn't willing to go through the intensive, advanced, traumatic autogenous bone grafting. So rather than just compromise, we offered her the clever solution of a very minimum trauma allograft blocks. So this was an introduction showing you the importance of having something like this in your dental practice and showing you the workflow of having bone block case in the aesthetic region and what can be achieved. But as we promised, we're going to tell you why and how. So the first part of the presentation going to be on why we can trust allograft blocks. And obviously, to be able to answer this question, we have to take you back to the dental school and go through some bone healing biology and physiology. So let's start. As we all know, if you look at the bone at macroscopic level, there are two different types of bone: the cortical, compact bone, and cancellous, trabecular bone. And they're very different from each other. If we want to take the femur bone as an example, and this is where we harvest our allograft blocks from, we can see that taking cross-section, we're going to have a core of cancellous bone and the surrounding is cortical bone. And you could appreciate the difference in the macroscopic anatomy. Cortical bone, compact bone, is compressed bone, and it will react to pressure completely differently. We know from our clinical studies, put pressure on that cortical bone, you'll initiate micro cracks, it will resorb and shrink. While put pressure on this beautiful cancellous bone, which is full of marrow spaces, full of good cells, all these good cells will get stimulated and you're going to get bone remodeling. And that's why, if you remember in your basic teaching in implant dentistry, that implants needs to get their primary stability from the apical 1/3, where there is plenty of cancellous bone, and definitely keep away from the cortical plate. So let's look in detail into the cortical plate. The cortical plate basically is made of units, and each of these units called an osteon. These osteon basically are circles of compact bone surrounding a canal full of arteries and veins. And that's why we have to be careful with the cortical bone. Compact bone means very little blood supply to the peripheries. When you compare it to the cancellous bone, trabecular bone, which is basically made of a network of bone framework called trabeculae, and the space filled with bone marrow and blood vessels. So you could appreciate the amount of spaces we have, how much blood vessels we have in that area. Now, bone marrow, even better, we know it's a specialized connective tissue. And the beauty of this bone marrow, that under the correct environment, an ideal environment, healthy patients, we're going to have the bone marrow producing red blood cells and many white blood cells, platelets, and even better, bone-forming cells. It contains fat cells, and remember this, because as you will see, as part of processing the allograft blocks from botiss, they do what we call defatting, which helps a lot. So it contains fat cells and it has other connective tissue elements. Now let's go from the macroscopic to the microscopic level. And if you look at the bone at microscopic level, you're going to have the woven bone, which is basically immature bone, the first type of bone which forms after having a tooth out, the first type of bone you have after bone remodeling around the dental implant. And should things go smooth without having issues, we're going to remodel into a more mature bone called lamellar bone. So now we know the difference between the woven bone and the lamellar bone. And now we're going to look at the bone healing. If I'm going to introduce you to a bone graft material, what do we need from that bone graft material? I appreciate, and I hope you appreciate, that we all want a bone graft which will have the ability to integrate with the host bone, number one, and with the implant itself. Otherwise, that bone won't be good. So what the biology tells us, that in the market, there are so many different types of bone graft, and they heal differently. They act differently. That's why we never, ever use one bone graft material for all clinical cases. Different cases will have different indications, and different indications will require different bone graft, which will act in different mechanism. What we need to remember in our clinical applications, we need to understand the biology. Our decision on which bone material I'm going to use for this case shouldn't be based on the cost or the marketing. It should be based on our biology understanding of the bone healing outcomes from time point of view, quality point of view, and stability point of view. Even if you use allograft blocks, as you will see in the second part of this presentation, there are so many different types of allograft blocks, and you're gonna need to deal with them differently. If you use a maxgraft cancellous block, It will have completely different healing time to unicortical cancellous block of maxgraft. Completely different clinical application. So we're going to talk about that in the second part of this presentation. But let's go back to biology. When we talk about how bone forms in a human body, there are three different ways. Number one, osteogenesis. And that's the ability of the bone graft to form a new bone based on osteoblasts which are present within the graft. But these osteoblasts need to survive the transplantation procedure and needs to stay viable to retain the capacity of forming a new bone. That's why if you take an autogenous block, which gives you osteogenesis, you have to be careful to make sure that you've managed to preserve these osteoblasts. Otherwise, it will be it will not act properly as an osteogenic bone graft. The second mechanism, what we call osteoinduction, and that is basically the ability of the graft to stimulate bone formation by stimulating the undifferentiated mesenchymal cells within the graft to turn into osteoblasts and start to produce bone for you. So you use a graft which has undifferentiated mesenchymal cells. They have the ability to transform into osteoblastic cells to form bone. And the third mechanism, what we call osteoconduction, and that's the ability of providing a scaffold, number one, and number two, try to encourage osteogenic cells from the surrounding host environment to migrate and colonize your scaffold to produce a new bone. And this is what we call osteoconduction. So let's look at the flow of bone healing. Let's say I've just opened my flap, put my drill, cut an osteotomy in the bone. Number one, I'm going to get hematoma. This will be followed by an acute inflammation. The acute inflammation will provide cells, inflammatory cells, but will also help to bring some osteoblastic cells. You're going to get some osteoblasts, you're going to get some precursors of good bone cells, which will provide us with bone. That's the inflammation. Now, in healthy people, this inflammation will not continue. While, let's say, uncontrolled diabetes, this inflammation will keep inflammation. So after that, you're going to get granulation. And granulation basically is the way where we encourage encourage blood vessels, encourage all the good things to come into this area from the surrounding host bone. After that, you start to get proliferation. Basically, osteoclastic response start to resolve the old graft. The moment after, these good cells coming into the bone graft, it will resolve the bone graft. And this, resolving the bone graft will release some bone morphogenic proteins from the bone matrix. And by doing this, this will stimulate the beginning of osteoinduction within the graft. And then at the same time, the graft acting as a scaffold, encouraging all the good cells to come into the graft and start the osteoconduction process. After that, in healthy people, you're going to start to have woven bone forming, and that woven bone will gradually start to remodel, forming lamellar bone. And with time, we're going to have all that bone block incorporated by host bone, and with time fully replaced by healthy natural bone. So this is what happens in ideal bone healing process. This is the cascade of bone grafting in implant dentistry. So if I'm going to summarize, we said autogenous bone graft from a biological point of view is considered the gold standard. True, because it's the only graft which will give us osteogenesis and osteoconduction, osteoinduction. But the downside, the morbidity, the mortality, you put your patient through huge amount of trauma, as well as we will see later, high rate of resorption. Now, allogenic bone graft can act as a scaffold, give us the osteoconduction, and if it's demineralized, some data suggests it has an osteoinduction ability. Xenograft bone graft basically will only be acting as a scaffold, allowing the bone cells, the blood vessels to go in between the spaces and act as osteoconductive. So going back to the bone graft, what do we need to get good bone graft healing in the in the area where we're going to place an implant? You want to have good graft type and form. You need to check, is it cortical, is it cancellous, or what is it exactly? The size of the graft makes big difference. If you're grafting an upper lateral, it's completely different to grafting a full arch case. The defect of the size, the size of the defect and the morphology, is it one wall or three wall defect? It makes big difference. And let's not forget the surgical procedure and the operator, because obviously different things work differently in different people's hands. And those who are used to use autogenous blocks, they will have to change their technique when they come and use allograft blocks. They're not all the same. And obviously, patient factor. Uncontrolled diabetes, as I mentioned, will continue having that acute inflammation and will not progress into the granulation, proliferation, osteoinduction, osteoconduction stages. So when we talk about the difference between a block and particulate bone, let's remember that the good thing about particulate bone, it has good, fast incorporation. But the downside, it will always have problem with the stability. That's why whenever we do particulate bone, we like to have a membrane. And we like to stabilize the membrane using tacks, sutures, whatever. Membrane stabilized by flap on the top, it's a recipe to disaster. Obviously, particulate bone will need to be included in this secluded space and will undergo extensive unpredictable resorption, especially if it's autogenous. While bone blocks, the advantage of the bone block that gives you structural and dimensional stability. So that's the main advantage. It will take time to integrate because, of the size of the block. Autogenous blocks being reported to give us resorption up to 50% in some cases and will require fixation. Therefore, you'll have to be a bit trained how to use these bone blocks. Now, this is comparing particulate versus bone block. Let's look at the type of the grafts. We all know alloplasts come from the lab. And the good thing about the alloplasts, they have an ability to remodel really fast. But the problem with alloplasts, they give us what we call controlled delayed resorption. Therefore, in my hands, I'm happy to use alloplasts for sinus graft, for ridge preservation. I will never use alloplast to recontour or recreate a facial plate because it will look good today, it will look good in 6 months' time, it won't look good in 2 years' time. You get delayed controlled resorption. False positive. Allograft remodels fast, not as quick as the alloplast, and it does resorb not as much as the alloplast. That's why personally, I'm happy to use allograft to cover exposed implant threads if I cannot provide autogenous bone, because I know they're going to give me quick turnover into good healthy bone. But again, I will never rely on allograft by itself to give me that beautiful convexity which is needed to give my final implant crown the natural appearance. Now, xenograft, as we all know it, it will give you very, very slow remodeling, if any. But the good thing about it will give you good long-term stability. And that's why it is useful to build convexities, especially in the anterior region. let's go back to the main question. Do we use one bone material for all cases? Definitely not. Can you say, I will never use bone blocks, I will always use particulate bone? Definitely not. One size doesn't fit all, as you've seen it possibly in my previous webinar last year. So the question, when do we use particulate, when do we use blocks? We've already talked about it. But if I'm gonna just give you this equation, for bone formation, you need a triangle with 3 parameters. You need stability, you need time, enough to give us blood supply angiogenesis. If we have a big defect, which means more time is needed to give me the angiogenesis, even if I have mesial and distal bony peaks, definitely GBR not going to be very reliable unless you do something to make it stable. If you have a defect, the surrounding bony walls are not going to be enough to give me stability, definitely particulate will not do the job. So you need to balance, you need to study the case and balance your decision what to do for this specific case. We need to remember it's all about angiogenesis. There are patient factors, but there are some surgical factors and treatment planning factors. Why do we need angiogenesis? Because blood supply will give us the proliferation, will bring the good cells into the area. And from there, as I explained earlier on, will help us to have the bone. So let's go back to the title of this lecture, bone block grafting. When will I do bone block and only bone block to achieve reliable good results? Number one, no wall defect, such as the top right, you could see in knife edge ridge. This is definitely a no wall defect. Number two, in the bottom left, one wall defect. Number three, in the bottom right, it's a two wall defect, but it's such a huge defect. When I know I'm gonna have issues with the stability, therefore it will not be stable long enough for the blood supply to come and cover all that bone in that area. Therefore, whenever you have unfavorable two-wall defects, you need to think again and maybe look into bone rings, for example, to want to give you stability, or allograft blocks. So this was a quick introduction into part one, bone healing. Let's move to the exciting part of the webinar. Basically, let's go clinical. Allograft blocks. When we talk about allograft blocks, as I mentioned earlier, they're not all the same. Allograft blocks being used by orthopedics routinely since the 70s, if not before. So it's nothing new. Yes, it's new for us, but come on, life started much, much before us, guys. And if you go into the dental literature, you're going to find loads of orthopedic, well-conducted studies showing that allograft is reliable and predictable. However, there are different types of allograft. There is the free-frozen bone, there is the demineralized freeze-dried bone, and there is what we use in implant dentistry routinely whenever we use blocks, the freeze-dried bone allograft, which is the mineralized bone blocks. The advantage of these that they are available, they have less risk of the disease transfer when compared to the frozen bone, also low risk of immunogenicity, induce new bone formation, and therefore good healing of the osseous defects faster than the frozen allograft, and have better mechanical abilities compared to other allograft bone. So whenever you want to go for an allograft bone, make sure you want to go for a freeze-dried bone allograft. You get the best results. Now, the maxgraft blocks, which we use from botiss, they're unique in their purification process. They go through an extensive purification process. However, it keeps the structure of the block, give us macroporosity, very similar to the human bone. A huge advantage, it retains its collagen matrix, but also that part will be highly mineralized. So nearly 70% minerals, 30% organic phase. Together gives you the stability. Make sure it's not going to be brittle in your hands. And also having the organic phase helps you to be osteoconductive, definitely, and sometimes you could argue can be osteoinductive. Now, the beauty of these blocks, it provides the scaffold because they have porous structure, so allow for optimal revascularization quicker than autogenous blocks, definitely. Encourage the migration of cells such as osteoblasts, osteocytes into the surgical site, and have good and fast bony integration. Now, the other advantage of these blocks by botiss, that the way they purify them, they leave 5% moisture through the lympholization stage. So you don't need to rehydration. If anything, I know some of my colleagues will like to rehydrate them to make sure you attract the blood into the block. But looking into these blocks, the way they're being treated, because of the 5% moisture, they will act, as hemophilic. They will attract the blood, so you don't need to overhydrate them. Definitely with cancellous blocks, as I'll show you later on, you should avoid hydrating the cancellous blocks. Otherwise, it will definitely affect the mechanical properties. Now, going back to maxgraft blocks, according to the composition, there is the pure cancellous block, or you could go for the unicortical cancellous. I looked into the data. There isn't a single random control trial comparing cancellous to unicortical cancellous, which means there is no evidence that one is better than other. I know some of my colleagues have anecdotal feeling that cancellous heal quicker. However, other friends, they have anecdotal feeling that unicortical cancellous give them more stability and easier to fix during the bone block procedure. I know people who are switching from autogenous blocks, they're going to find it easier to move to unicortical cancellous before going to cancellous blocks from a manipulation point of view. So the cancellous block, basically, it's structured in a way it's full of bone marrow spaces, it's porous, and it has fast absorption of blood, therefore faster healing. And I said you don't need to rehydrate it. With the cancellous block, personally, I'm happy to leave them for about 16 weeks, after which I can go back and place my dental implants. If you leave them longer, there is a risk of resorption taking place. So, to summarize, cancellous blocks don't rehydrate. Definitely don't rehydrate. Number 2, leave them to heal 16, maximum 18 weeks, not longer. Otherwise, they will start to show some resorption. And number 3, when you want to come and fix them, you really need to be gentle, because you put too much pressure. If you use the lag screw technique, you're going to break that block. Let me show you a case. This is Sarah. Sarah came with missing lateral and canine and failing first premolar. So she was referred to me by her dentist, and as you could appreciate from the pre-op CBCT, we have minimum bone thickness, 3 millimeter at the ridge, and you could see the failing first premolar has some root decay. So we decided first to go ahead with the bone grafting, so we can use the central and the premolar to support a fixed temporary adhesive bridge to keep it short span. And that's what we did. And you could appreciate the ridge. We opened the flap, and you could see it's minimum bony height thickness with massive undercut underneath. So from there, we went and we decided to use all cancellous block, and you could see how it's full of spaces. Definitely It will attract blood, bony cells easily. Now, the thing with cancellous blocks that you will need to prepare the host bone. You will need to shave the block, but also do some preparation for the recipient side to achieve good intimate contact at little amount of pressure on the block. Cortectomy, obviously, to get all this nice blood coming out from this cortical ridge. And this is the block. You hold it, shave it. The trick here is to try to manipulate the block in a way and manage the block in a way to make sure you don't have any sharp corners and very tiny hydration, irrigation as part of the trimming. Definitely don't do a lot of irrigation. And then that's the block. In this case, I split the block into 2 pieces and we managed to graft the area. So I'm sorry, you can never trust technology, but here we are. So the bone block, I've split the block into 2 pieces. I'm using the allograft particles just to fill the gaps. And what I've learned that you really need to use tiny little screws, literally 1.3 thickness, not more. The drill I use is a 1.0 millimeter drill. And try whenever you want to put your screws, don't put them all in one line. Try to put them oblique, because when you do them oblique, you don't to put too much strain at the same vertical line. So this is the block, and these are the allograft particles. I like with cancellous bone, and this is another difference, I would like to use a membrane. And I would like to have proper secluded space. So I will use even 2 membranes if needed to provide an isolated area. Obviously, closure under no tension. Make sure you get good primary closure under no tension. And then we said you fix your adhesive, fixed temporary. Dentures will just ruin everything for you. Now we left it 16 to 20 weeks healing time. We took a post-op CBCT, and you could remember we started with 3, now we're up to 9 in certain area, 8.2 in other area. And you could look how nicely integrated that cancellous block all together. So we booked the patient for a 2nd stage, and the moment you raise a flap, we decided to place implants at the canine and the premolar. By extracting the premolar, placing an immediate implant, and putting an implant in the block at the canine and leaving the lateral as a pontic. You could see how the bone even start to grow on top of your screw. The moment you remove your fixation screw, you've got nice blood coming out, which tells you that this graft has well integrated. And you could see the thickness. This is my 4 being extracted, my surgical guide, pencil marks, and you could see the implant placed within the prosthetic envelope because I've got sufficient amount of bone to help me to place the implant within the prosthetic envelope at the correct 4th dimensional angulation. I've got more than 2-3 millimeter covering my implant. Obviously, we use some autogenous chips to fill the labial gap in the immediate implant placement. And from there, I like always to use healing abutments. I don't use cover screws, even when I'm burying my implants, to do better GBR. You could see how the screw is out, the final screw is out, and blood coming. Putting my Cerabone xenograft just to give me that stability on the long term. And then membrane stabilized with pins. And then again, closure under no tension. And this time we made a 3-unit temporary rochette adhesive bridge, fitting nicely. After 12 weeks, that's all what we needed. Implants exposed. And then after a while, impression taken. And you could appreciate from the CAD CAM of my implant model how we managed to bulk the bone and how we got a screw retained restoration using straight screws in the ideal positioning. From there, we got the final restoration fitted, screw retained, because we managed to bulk the bone using these allograft blocks, and we've got that nice wedge ridge. Now, the other type of blocks, you could go and use the unicortical cancellous block, and basically the advantage that you have this cortical plate covering this cancellous block. So it will give you better mechanical properties. It will still have cancellous bone, so it will give you the osteoconductive ability. It will attract bone into the cancellous bone. But you need to remember, because of that cortical plate, it will take more time to get complete integration. So in these cases, I would like to give them 24 weeks. On the other side, having that cancellous block will give you better long-term stability. So this is Kerry. Kerry came to me with her Maryland crown, which been there for a long time. She had some issues with her space design, but now she made a decision. She would like to have an implant instead of this extracted tooth, which been extracted a long time ago. And she would like to have a veneer also. So we did the wax up, showing her how the space analysis is going to be. And you could appreciate the depth. Pre-op CBCT around 3.4. We decided to give her a bone block because we wanted to place the implant in the correct 4-dimensional placement within the prosthetic envelope. I'm checking my bony peaks to decide my flap design. And from there, the flap was elevated gently, and you could appreciate, again, it's a one-wall defect. We use the unicortical block. Now, the difference that with these unicortical blocks, I personally tend to hydrate them. And I will hydrate them for a good 10 minutes in saline. Just soak them in saline. So from there, I will do the measurements, and then I will shave it and adjust it. And make sure, especially when there is cortical plate, make sure the corners are well smooth and round, cortectomy, and then the block fitted. Now, the other advantage of the corticocancellous that you don't need to adjust the recipient site, because the moment you soak your cancellous bone and you start screwing your fixation screw, this time using the lag technique by making the osteotomy in the recipient bed narrower than the osteotomy, or the hole in the recipient bed narrower than the osteotomy or the hole in the block, you can screw really tight without worrying it will fracture, because you've got a nice cortical plate. But as you screw really tight, the cancellous bone will shape itself to the recipient bed, and that gives you good stability. And here we go, you could see good stability. And from there, you could get some autogenous or allograft blocks, just put them around the corners. You could put a membrane or not, it's up to you. In this case, I use Cold Protect, just 6 weeks, because I use some other particles around the block. If I didn't, having a cortical plate means I don't need to use a membrane. And then from there, I will undermine the flap, ensure closure under no tension, and then I will start using sling sutures around the margins and make sure everything is closed under no tension. Here we go. Go back to the fixed adhesive and then progress from there. Wait, this time you have to wait good 24 weeks to get good bony integration. After 24 weeks, you could see the convexity. You remember where we were 3.0? That's the convexity. We've got nice soft tissue healing. Post-op CBCT, nearly 7 millimeter, which shows you well integrated. The cancellous parts integrate nicely with the bone. You will always see that cortical plate. But so what? You know, Autogenous bone blocks are made of cortical in most of the cases, so that doesn't worry me at all. And that's 7.6, at the crest of the ridge. Now we're raising the flap, placing the implant within the prosthetic envelope in the correct fourth dimensional placement. And then you could see how everything went well. You've got an osteotomy with sufficient amount of bone. I will still put some sera bone around the margins just to build, to get rid of that step effect. Put adjacent membrane, stabilize using pins. And from there, closure under no tension. Leave it 12 weeks. Implant will start to expose itself. Take the implant out, put a temporary crown. We, according to the initial wax up, we build a filling on the other tooth to start to sort of correct the space analysis. And from there, we waited for the temporary to heal better, give us good soft tissue contouring. And now we start to communicate with the patient. Do you like it? Do you not like it? We have different scenarios, different options. And we decided to go for a veneer on her upper right central incisor and screw retained restoration on the upper left, done by my friend William in Napoli. We send him the work, really high-tech work. And from there, we do all the design, all the digital planning, and we've got the screw retained restoration. I use silver plugs instead of Teflon nowadays because it's bactericidal, and you could appreciate the convexity around the veneer, very similar to the convexity around the implant. And we reach a point when I've got a restoration looking good, feeling good, and we've got the convexity we want. If you remember, we started with 3.0, we ended with 8 millimeter. It allowed us, using the unicortical block by maxgraft botiss, to put the implant in the correct position. And here we go, we've got that convexity. Now to finish, these are the CAD CAM blocks. I've done loads of them, and I found them very useful, especially in my hands when I have more than one unit defect. I appreciate they're a bit costly, but I think when you start to have more than one more than one implant, it becomes cost effective. Even if it's one space, I think, you save a lot of time, you save a lot of hassle during the operation. And nowadays, some of my patients come and ask for them. So in this case, we decided to place implants for John. Even using the shortest implant, we were very close to the nerve. So we realized we need to do vertical augmentation as well as horizontal. I send this to botiss and they design it for me. I make sure we're away from the mental nerve. They send me the dummy. I show it to the patient. I communicate with the patient. That's part of the consent. Okay, this was my first case I've done actually, hence it has the longest follow-up. Cortectomy. The block just fit nicely like Lego, amazing fit. I wouldn't put too much screws at the moment, and I would design the block to go on the lingual side to give me some retention. But here we go. From there, closure under no tension, soft tissue management. Just to remind you where we are, where we are. You remove the screw, as you can see from the side, we've got blood coming out. Implant placed within the prosthetic envelope, tissue level implants. 8 weeks, after which we exposed the implants and took impression, and we fit a screw retained 3-unit bridge with the screw access hole within the occlusal bone. Now I understand that today I didn't share with you random control trials, although I'm part of Cochrane collaboration, and I've published a lot of random control trials on different topics. But I shared with you my clinical experience. And to me, I'd like to call it clinical-based webinar, where I've showed you how about 5-6 years ago, I switched to allograft blocks. I have cases with 4 or 5 years follow-up, perfect results, good stability. And what allograft blocks help me to is basically provide my patients with the same high quality treatment, but at a fraction of time, at a fraction of trauma. And I'm having more and more people coming and accepting my treatment plan because they know they can have it easier without the hassle of autogenous blocks. Thank you very much for being with me today as part of the botiss webinar. I'm Hassan Maghaireh from Leeds, and I had the pleasure of being with you, and I'll be more than happy to answer your questions either now or by email. This is my personal email, and you could also visit our BAIRD Academy, where we have regular courses, bone grafting, soft tissue grafting, implant courses in Leeds and all around the world. Thank you very much. Right, so what I'm going to do now is to look at the questions, if we have any questions. I think everyone is happy. Everyone just saying thank you, but we don't have any questions. Neil. No, I've got Neil. Do you find you have to perform vestibuloplasty and apical flap advancement to increase the keratinized mucosa? Neil, well done. I think you've noticed in the last case, yes, we had to do vestibuloplasty, especially when you do vertical bone augmentation in the lower jaw. So we did vestibuloplasty, and it helped us to increase the keratinized amount of keratinized mucosa around the lower implants. Also, now I'm looking into these balloons, hydrogel balloons. Basically, before you do your vertical bone augmentation, you open a flap and put this balloon, you fix it with a little titanium screw, and then you put the flap back, and this hydrogel balloon absorbs fluids and gradually, so it starts to bulk the soft tissue, and that helps you to have excessive soft tissue before you even do your bone grafting. But yes, I totally agree with you, and this is what I've done with John. The last case, we did vestibuloplasty, and we helped us to increase the keratinized mucosa. Right, okay, that was Neil. Thank you very much for being with us. Amar, thank you, Amar. Nice to see you here. Bogdan, how long for the CPCT design graft to integrate? It is all cancellous, Bogdan. So you apply the same principles. All cancellous, 20 weeks. Cortico cancellous, 24 weeks. So all cancellous, I would take a post-op CPCT at 16 weeks, and then I decide how soon. Usually I find myself going 16 to 20 weeks. Okay. We have a question from, please explain to me how to achieve the free tension closure. Free tension closure, it's important. You could do periosteal release whenever you can. In the lower jaw, it's a tricky business, so I would rely on blunt dissection of the lingual flap. No cuts, nothing. I just detach the muscles from the lingual flap, and that just makes the lingual flap overflow and then closes nicely. I've just talked about also having this hydrogel balloon, which we're working on, and I think it's a clever idea. Okay, any more questions? I think we talked about the tension-free. Excellent. Once again, thank you very much for being with me from UK, from Middle East, from Europe. It's always nice to come back to botiss webinar, and I look forward to meeting you all in botiss Congress in Berlin early November. So all the best. Okay, one last question about membrane and special kind. Membranes, I like to use a Jason membrane. What I like about botiss is that they offer you two different types of membranes. So if you believe in long-term membranes, then Jason. If you would like membranes resorb quickly, call Protect. It depends what do you believe. Personally, when the defect is large with bond block, I use Jason membrane. but I think the real trick is in stabilizing the membrane rather than anything else. Botiss, thank you very much for the wonderful invitation, and I look forward to meeting you all again in Botiss Congress in Berlin. Have a good day, everyone. Bye-bye.